So in the next 15 minutes, I'm going to talk about pulmonary MRA and perfusion, but focus primarily on pulmonary MRA, and in particular in the setting of pulmonary embolism. UW-Madison does get research support from GE Healthcare, and gadolinium-based contrast agents have not been FDA approved for pulmonary MRA. Why am I going to focus on PE in particular? Primarily because it's a common problem that is associated with substantial morbidity and mortality. And although we primarily image this with CT, I think there is definitely a role for MRA that I'll go into in the next several slides. And then I'll explain how we do it at UW-Madison, and then finish up by talking on whether or not it is in fact an effective imaging modality. So is there a need for MRA? We've been talking, several of the presenters have talked about the how good CTA is for a variety of applications, and that's also true for looking for PE. CTA is the primary imaging modality for trying to detect PE with a very high negative predictive value that is necessary as a screening study. And if you have a negative CTA, you can pretty much stop there. You've ruled out PE. You can move on to the next item in your differential diagnosis. However, CTA does have some problems associated with it. It does require the use of ionizing radiation, as well as ionated contrast material that's associated with nephrotoxicity. A fair number of patients have allergies, including significant allergies to ionated contrast. It is a little bit more complex in terms of timing your image acquisition. You've really got one shot at getting it right, and you've got to make sure that the patient doesn't take in a deep breath and cause interruption of the contrast bolus. And then if you look at the data from the PIOPED-2 study, looked at over 7,000 CTA studies, there was not an insignificant number of patients in whom other imaging modalities would be beneficial. So there is definitely a need for alternative imaging strategies in patients suspected of PE. And so I think those are the patients that we're targeting for MRA. There are several important challenges for MRA when trying to image PE. We do have to image the whole chest in a really short amount of time. Most of these patients are short of breath, can only hold their breath for 10 to 15 seconds. And then we need to image even the smallest vessels in the lungs. So you need a spatial resolution that's on the order of 1 to 1.5 millimeters isotropic. One of the largest studies comparing MRA to CTA is the PIOPED-3 study. This was published almost 10 years ago now, or 6 years ago. And unfortunately, there was a lot of heterogeneity in the technical success of MRA. And the conclusion from that study was that MRA should only be considered at centers that do it routinely and do it well, in whom other conventional tests, that being CTA, are contraindicated. One of sort of transitioning a little bit, this is sort of the evidence, the appropriateness criteria table that was just published by the American College of Radiology. What tests are appropriate in patients suspected of having PE. I was pleasantly surprised to see in the most recent update that just came out this summer, MRA moved up from a 4 to a 6. So it's still in that intermediate category of may be appropriate in certain patients, but at least the evidence supporting the use of MRA is increasing as more and more data becomes available. So how do we do it at UW-Madison? Scott Nagel just recently published a paper in the European Journal of Radiology that outlines our approach. And I think the key to doing it well and doing it consistently is to have a simple protocol. and a fast protocol, something that can be done in 10 minutes or less. And so we've really pared it down to just the essential sequences, our localizers, our 3D MRA sequence that we do before, during, and after the administration of contrast. And then we do a real rapid T1 weighted fat suppressed sequence at the end to characterize other potential abnormalities that we might encounter in the lungs. And we do the exact same acquisition at 1.5 Tesla and 3 Tesla, and this is less than 10 minutes of table time. Patient gets on and off in less than 10 minutes. And that's essential when you're trying to compete with something like CTA, in which the scan is less than a second for the whole chest. And then one of the other things that we've learned in the last 8 years or so is something that Jeff Mackey alluded to earlier, the importance of having a well thought out contrast injection or bolus injection protocol, something that is reproducible, that at 2 in the morning and at 10 in the morning, it's the same injection. It doesn't matter the experience of your technologist or how many of these studies they've done before. Keep it simple. And so we always inject 0.1 millimole per kilogram of a gadolinium-based contrast agent. We dilute it up to 30, and we inject at the same rate in everybody. It's a 20-second acquisition, more than sufficient for our 15 to 18-second scan time. We use bolus tracking to ensure that the contrast is in the pulmonary arteries during our image acquisition. And then we also have the technologist instruct or coach the patients on how to do the breathing maneuver appropriately. Again, like with CT, we want to avoid having the patients take in a deep breath during our image acquisition, because if they take in a really deep breath, that's going to bring in all that unopacified blood from the inferior vena cava and give you that same transient interruption of the contrast bolus that we see with CT. And when things look well, we can see out to the second or third order subsegmental pulmonary arteries. And then here's just sort of another patient that did not have PE, showing sort of the dynamic nature of our acquisition. We start out with our during or first pass phase when the contrast is first coming into the pulmonary arteries, and then we acquire 2 subsequent scans just in case the patient coughed or sneezed during the first pass, or maybe they couldn't hold their breath that well. The contrast coming in sort of shocked them. You've got a couple other chances to get really good imaging of the pulmonary arteries. And in the case of these high spatial resolution images, isolating your image acquisition to when just the pulmonary arteries are enhanced is less of an issue. You can use the high spatial resolution to differentiate the pulmonary arteries from the pulmonary veins. So what do PE look like on MRA? They look just like you'd expect them to see based on CT. Here's an example of a large filling defect in the main pulmonary arteries, a smaller filling defect in one of the left lower lobe pulmonary arteries, and you can also see small subsegmental pulmonary emboli very clearly when the patient, with image quality like this. One of the other benefits of using a dynamic acquisition like MR is that some of whether the during or the post phases, you can see these perfusion defects, and oftentimes these are the first clues to us that there is potentially a filling defect. When we do see a perfusion defect on our MRA, we look a little bit extra, spend a little bit more time looking at those pulmonary arteries more closely. With MR, you can also do MR venography to look for DVT. The MR venography was part of the PIOPED 3 trial, and that was it was a necessary component to get their sensitivity up as high as it was reported. We do not perform MR venography routinely anymore, given the fact that our MRA acquisition is as technically successful as it is. There are certain artifacts that are intrinsic to MR acquisition. Truncation artifacts in particular can be troubling when you're first getting started with pulmonary MRA. Nice study published by Peter Vanas a couple years ago compared truncation artifact to true PE, and you can use the relative signal drop and the persistence of that signal drop to try and differentiate between truncation artifacts and real PE. True PE have much lower signal than the truncation artifacts that you can see. And then now at the bottom of your screen, you can see some of the effects of scanning too early or too late. If you scan a little bit too late relative to when the contrast is going through, if you don't have contrast in those small pulmonary vessels when you're acquiring the outer areas of case space, your vessels look blurry, just like Jeff was pointing out earlier. If you scan too early, again, you don't have enough contrast in the vessels of interest. Of course, we're dealing with patients who cannot hold their breath. Often it's not at all unusual for patients not to be able to hold their breath for the 15 seconds. And if you encounter really bad respiratory motion, our technologists are savvy enough to know that it's okay to do a second injection. And usually the second time the patients are ready for that injection, they can hold their breath a little bit longer. There's also aliasing issues and G-factor issues to deal with when we're using parallel imaging. But again, by adjusting your parameters and your slice orientation appropriately, you can avoid most of these artifacts. There are other MRA techniques for looking at the pulmonary vessels or looking at lung perfusion. I'm not going to have enough time to go through all of those today. With respect to MR lung perfusion, there's been quite a bit of work in both qualitative and quantitative methods for pulmonary embolism, as well as other structural lung diseases and pulmonary hypertension. Another newer promising technique for looking at both the pulmonary vasculature and the lungs are the ultra-short TE techniques. This is data from an animal study that we did a couple years ago where we injected PE into the pulmonary arteries, and we compared our standard 3D single breath hold contrast enhanced MRA method to a free breathing ultra-short TE method and CTA. The ultra-short TE method performed as well as our contrast enhanced MRA method. So in the last minute and a half or so, I'm going to go over whether or not MRA is effective. If you look at some of the earlier studies that compared MRA to X-ray angiography or even CT angiography, the test didn't perform as well as you would expect it to or would like it to rule out PE with a high enough degree of confidence for it to become acceptable for routine clinical practice. But I think with the newer advances in parallel imaging that allow us to acquire a full chest MRA in 15 to 18 seconds, it has become clinically feasible at UW. We've been doing this for over 8 years. We've done over 800 patients. It's well accepted by referring physicians. It's robust, with less than 5% of these studies being non-diagnostic. We do it 24/7. Our residents do provide preliminary reads on call. And we target younger patients in whom we'd like to minimize exposure to radiation therapy, as well as patients who would have a contraindication to CTA. Skip that. We've recently done a retrospective analysis comparing the performance of MR to CT in age-matched patients. Interestingly, there were fewer positive cases of MRA than in CTA, fewer equivocal cases. In other words, we had a much higher degree of confidence in our interpretation of the MR images with a similar number of technically limited cases. And when you look at outcomes, there were fewer adverse events in the MRA population, primarily due to fewer patients being on anticoagulation and bleeding. So in summary, CTA is still the gold standard for acute PE diagnosis, but I would encourage you to strongly consider start doing pulmonary MRA in patients who have a contraindication to CTA or younger patients. Thank you.